Good afternoon, everyone, and welcome to the New York State Caregiving and Respite Coalition Virtual Resource Professional Webinar Series. Today, we are thrilled to have invited Miles Zakowski, who is an attorney with the law firm of Dutcher and Zakowski, specializing in elder law, including Medicaid and nursing home planning, special needs planning, veterans estate planning, probate and estate administration, and guardianships. Miles is one of the very few Western New York attorneys accredited by the VA to counsel veterans on benefits through the VA. In addition to various bar associations, Miles is a member of the Executive Committee of the Elder Law Section of the New York State Bar Association and the current chair of Monroe County Bar Association Elder Law Section. He's been active in addressing elder abuse prevention in our community and nationwide. Miles also serves on the County Older Adult Fatality Review Committee and one of only a few panels in the nation which reviews cases of deaths of older adults to assist in improving the availability of services in an effort to prevent future abuses and fatalities. In addition, he's the chair of the Rochester and Finger Lakes chapter of the Alzheimer's Association and a founding trustee of the Future Care Pooled Supplemental Needs Trust, which is where I first met Miles because I was the first director of the Future Care Community Pooled Trust, which you'll be hearing more about next month if you sign up for the Pooled Trust webinar that we're doing. So I've worked with Miles for 15 years, and it's my pleasure to welcome him to this webinar. If you have any questions, just put them in the chat, and I will forward them along to Miles as we go through. And I think that's it. So Miles, take it away.
Thank you very much. I don't know if you could see me or you're just seeing the slides.
We're just seeing the slides.
Okay, that's good enough for now. We'll switch it around a little bit. Also, today's topic is, I just wanted to spell out, it is a moving target. I'm also on the board of directors at the New York NALA, which is the National Academy of Elder Law Attorneys, and we have a New York chapter, and we're very involved in trying to understand this and directly work with the New York State Department of Health in an effort to get the regulations down and iron out some of the loose ends. There are a lot of loose ends. So I'm happy to be with the New York State Caregiving and Respite Coalition. I appreciate the invitation, Abby and Doris. So we're going to run to the first slide, which is our topic today are the changes to Medicaid under the New York State 2020 budget. And the law was to take effect as of October 1st. We're in mid-November. That did not happen. It's been pushed out. And we'll get into some more details of that. Also, if you have questions as we go, ask them in the chat so we can discuss that issue while we're discussing that topic, as opposed to trying to refresh our memories an hour or so from now. So one question that is often asked is what happens during COVID? And that's a great question because this is new to all of us. And really what's been happening is we're under a lot of emergency executive orders issued by the governor. So the governor of each state, typically during state of emergencies, has the ability to change the laws for a limited time period. In fact, in New York State, it's only 30 days. Governor Cuomo has been renewing that every 30 days for those things that are appropriate. So for example, you hear that the governor is forcing bars and restaurants to close at 10 o'clock. That typically comes as an executive order. And until he withdraws that or it expires within 30 days, that becomes the new law of the land temporarily. So the reality and the fear here under Medicaid is, first off, in the very beginning, if the building was closed and no one was physically going to the office, how are they processing any applications? And the new issue will be, how will they catch up? And then, of course, how will they manage all these community applications when they just created a higher bar for themselves as workers, as caseworkers. So the first thing to know is that as of March 18, and in some places I've read that it goes back March 1st, if you're already getting services, you will not lose it. There's what we call a GIS, which is a government information system that is used to disperse this information throughout the year. So we know it's got a 20, it was the fourth memo of the year, applies to Medicaid assistance. And essentially, it was renewed through the federal government until January 30th, which means, as we will talk about in greater length, that the October 1st deadline of the changes has to actually go beyond January 30th, simply because no one could lose their Medicaid and government won't allow us to implement this look back period, which is going to be a large topic of what we're talking about. So what we're seeing in both community and chronic Medicaid, chronic being when you're in a nursing home, you're applying for chronic Medicaid, community meaning I'm still living in the community, my home or assisted living facility or some congregate community. The Medicaid team that reviews your eligibility is assuming what we call self-attestation. So local Department of Social Services is not currently verifying that the information you submitted is accurate. They're taking your word for it. And of course, under penalty of perjury, whoever's signing the application is stating that it's true. But there will come a time where the applicant is going to have to prove the income, the assets, and potentially defend against the penalty. So recertifications currently, you're already on Medicaid, is being renewed automatically for a period of 12 months till the next renewal period, although it's unclear what's going to happen going forward. I mean, we are facing as a community and as a state and as a nation an increase in COVID. Will that mean that the caseworkers at the county office building on Westfall Road cannot go physically to their office? Will they be quarantined at home? Will we have a state shutdown? Will we have a federal shutdown? None of these are known, so that's why you'll hear me repeat, this is a moving target because we simply don't know what the changes will be. We are working with, we being New York State Bar Association Elder Law Special Needs Section, we being New York NALA, National Academy of Elder Law Attorneys. We're working with the legal department at the Department of Health to fine tune some of this and make some sense out of the changes. So I'm going to get into a little bit of the background and the history of how we got to where we are today. We in New York State live on a fiscal budget, meaning it is not a calendar year. It is a 12-month year. It begins April 1st and ends on March 31 the following year. What happened typically for probably 20 years consecutively, the legislature was unable politically to come up with a budget on April 1st. It was often very late. In the last several years, New York State has managed to come up with budget on time. You may not like the budget, there may be budget cuts, but it was introduced right around April 1st as political climate changed a little bit in Albany. So the fiscal year budget for we call it 2020 budget. It's actually starting on April 1st of 2020 and it runs through March 31st of 2021. That fiscal budget was passed. April 1st was a Wednesday. They stayed through the night on Thursday, and at 3 a.m., a budget gets passed. So how did we get to where we are? Well, first of all, many months prior to that, and you recall many years ago, New York State had what's called the Medicaid Redesign Team, the MRT, Medicaid Redesign Team. And the purpose of that was to figure out how to save money on Medicaid for the state of New York, because Medicaid is a very expensive program. New York is probably the most liberal or giving of all of those programs. New York's threshold, for example, for how much money you can have in assets is $15,750 in the year 2020. Some states around the country are still at $1,000. So you could see that the definition of poverty level is different in different states. So the result of the Medicaid redesign team number 2 was to suggest ways for New York State to close a budget deficit. Prior to COVID, when the redesign team was first deployed, we had roughly a 4 to 5 billion with a B as in boy, $billion deficit that legislators and the governor thought could be closed substantially with redesigning Medicaid. Fortunately, due to COVID-19, New York State's deficit is probably in the $15 billion range. So that changes things quite dramatically. I don't know what other ways the government will find to save money, but I lay that out as a background simply because what we need to be aware of is that despite in number 3 here, the governor's expression that we're making these changes to help New Yorkers stay in the community, the reality check is that the purpose of this change was to save money. Eligibility is more difficult, lives of seniors will be more difficult, and those with disabilities, they're all going to be impacted. So you're going to hear me repeat this multiple times, that this is a moving target. So let's go to a summary of some of those changes. Now, there are a lot of things that are not yet worked out, but there are 3 major changes. Really, 2 that's of the first 2 are of great concern immediately, and the next one is something we'll be working on over the next 2 years, basically. But the first thing, and you probably have heard this, but it's a little unclear as to what it all means, is that there is now a look-back period. So again, in an effort to give you some history, in 2005, under George W. Bush, there was a Deficit Reduction Act. So we had a very high deficit as a federal government. We owed more money than we were bringing in, or traded more than we bought more than we traded out. In order to reduce the deficit, there were major changes to the Medicaid rules from a federal perspective that took place February 8th, 2007. So 2008. So as a result, we had a look back period at that point nationally of 3 years, and you can't be more restrictive than the federal government, but you can be a little more lenient. Though again, that would cost each state more money, because Medicaid is a federal program, but Medicaid is administered by the states. So it is not, we don't get all of our money in New York State from the federal government. We get reimbursed and we get some money from the federal government. Compare that to the other kind of health insurance of a similar name, Medicare. Medicare is 100% paid for by the federal government. New York State pays no money into Medicare system. As employees, we pay into the Social Security system, the Medicare system, the Medicaid system. But for Medicaid, the states are actually almost a partner with the federal government. So that's why you'll see in 50 states, there are 50 different sets of rules. And unfortunately, each county has a different way of implementing those rules. So the reality is there are many, many, many conflicting rules depending on where you're applying. The difference between how Monroe County...
It's Doris.
Yes.
I have someone requesting that you adjust your mic. They're having a hard time hearing you.
Okay, let me see what I can do with that because I'm wearing a headset. Bluetooth. So let me just
There's
see
just been a little bit of you cutting in and out.
Okay, let's see what I can.
Thanks. Oh my goodness.
Let's see. Is this any better?
Well,
Is that any better?
yeah, just keep going
okay?
and we'll see.
Okay.
Yeah, I think it's okay.
Let me know. I've got lots of options, but it's disruptive, and but I've got, for whatever it's worth, I'm at my home office and we have green lights, so we've got literally almost a gigabyte of upload, and I'm using headphones. I could always switch to the computer itself, but then you're probably going to get more background noise. All right, so the look back period, if you look back in 2008, was 3 years, and it changed to 5 years. So we're living with that 5-year look back period around the country for 12 years. Now, what the Medicaid redesign team recommended for community Medicaid is that we have a 5-year look back period as well. So what does that mean? Let's stop a second and talk about what a look back period is. When you apply for benefits, and this is common with Medicaid, nursing home Medicaid, you apply for benefits, there is a financial criteria as well as a medical criteria. The financial criteria is that you have assets below a certain threshold, which in New York is $15,750. And we also have an income threshold, which is different from nursing home care than it is for community care. And if you have more income, you either are ineligible or can use that excess income. I'm going to get into greater detail on this. Use the excess income for paying medical expenses, or in the case of community Medicaid, we use a community pooled supplemental needs trust. So the look back period that was ultimately passed by the New York State Legislature in April has half of that 5-year. Instead of 60 months, it's 30 months, so it's a 2.5-year look back period. Meaning when you apply, you have to provide documents to the local Department of Social Services of 2.5 years or 30 months worth of every bank statement, every financial statement, every financial transaction that you engaged in during that time period. You can imagine that that creates a difficulty right off the bat, because you have to first have that information at your fingertips or access that information somehow. That can be difficult for many people. So if you, and the purpose of a look back period is if you gave away, gifted, or if you transferred an asset for less than fair market value. So let me give you some examples of that. But if you did that for less than fair market value, a penalty would be imposed. So I ask clients all the time, have you made any gifts? No, we haven't made any gifts. Just Christmas time, birthdays, etc. Oh, $20, $50, whatever. But I gave my daughter $20,000 toward the down payment on her house. And somehow they may not see that as a gift. Or I gave my car, my junker car, rather than trading it in, I gave it to my grandson. Those are gifts. And the value of those gifts are counted against you, and you'll be penalized for that. So that's a concern, and we will deal with how that gets addressed. But you'll be penalized, which means that you will not get the services provided by Medicaid at no cost to you until that penalty is cured. So right off the bat, what this look back period means to community Medicaid, our clients, loved ones are not going to get the services unless they pay for it themselves during that penalty phase.
So Miles, we have a question.
Sure.
Is this a guideline for folks wanting to get into MLTC or PACE? I mean, they have to have their Medicaid eligibility first, right? Before they can get into those programs. So
Right.
Okay.
They have to first get your eligibility, and then you can apply into specific programs. I'll tell you right off the bat, the waivered programs, I mean, this is the silver lining perhaps, or any good news that we can make of it. The waivered programs are excluded. So OPWDD, nursing home diversion programs, or TBI waivers, those are excluded. So there won't be a look back period for those. They are not required to meet. That's an exception built in. But if you're looking for some type of personal service care or CDPAP, the community directed personal service, you want to hire home health aides. This is really designed at home health aides. So if you need that help for the purpose, the goal of staying at home, then you're going to have to meet this new criteria. Okay? So that's number two, is that this eligibility criteria has changed, and there's a typo in one of the slides. When we get there, I will explain it to you. Basically, they heightened what we call the standards. They raised the bar. So while you might have qualified last year, you might qualify today, you may not qualify after this takes effect, which means you have to find an alternative. You're either going into a nursing home, paying for this by yourself at home, or you have family members who are going to do it for free, or address, even if you address the look back period in the financial piece, if you don't meet this new criteria, you're done. You're not going to get this Medicaid. So what this means from a government perspective is they're not paying for your care. So it saves money to the state government, right? The last major change is the determination of eligibility for enrollment in these two programs, the personal care services and the consumer-directed personal care services, will change from local Department of Social Services, managed care plans, or Medicaid managed care. So right now, the way it works is an independent agency hired by the county or delegated by the county comes in, and they're going to provide the service. So they know what they can handle. They've seen this in other patients. They're familiar with it, and they come in and assess, do you need the services, and how many hours a day, a week do you need? So that is being shifted to an independent assessor who's contracted with the Department of Health in New York State, and they have 2 years to get that done by October 1st, 2022. Now, what that typically means, go ahead, Doris.
Well, the question is, so Maximus will do the initial assessment and determine the hours, or does the MMLTC?
Either one, as the Department of Health will ultimately decide. Again, this is a moving target, but like right now, we have Maximus. That will continue until the local Department of Social Services decides they're going to give the contract to someone else, which is not a simple process. So I doubt that that's going to happen. Or until the state government, the Department of Health, says we've now selected an independent assessor, which may turn out to be Maximus. I don't know if they're applying for the contract, or there isn't even a request for proposal yet out there. So we don't know what that's going to look like. But the major change is that the assessment, in order to get past square one, your doctor was involved because they know you and they can write out this person suffers from these following ailments. Now someone independent who does not know you and is not your treating physician has to do this assessment, which in some ways is almost a recipe for some problems, because are they going to be capable of assessing what you need? And Doris, I know you can speak to this as well. Our experience has been we often recommend that a geriatric manager, a nurse, or somebody be hired by the family to attend this Maximus assessment, because many adults, if you say, how you doing? They say, I'm fine. They're not likely to give you a list of 20 things wrong with them. One, they may not even remember all those things. And two, it's part of our own pride of like, hey, I'm doing fine. The reality is, if someone, if you can get up out of that chair once, you pass the test of being able to ambulate on your own. The reality is someone who's advocating for you might be able to tell Maximus that, oh, but she fatigues early, and if she sits down and tries to get up again, she won't be able to. Something along those lines. I don't know if you have anything to add to that, Doris.
Well, I think there's just maybe a little confusion. So the comment is the MLTC was doing the assessment after Maximus assessment was done to determine what you're eligible for. So who has the ultimate authority about how many hours you would get?
Okay, so
MLTC?
Well, let's look at what is happening now. Maximus determined that you were eligible for this program, and the MLTC determined how many hours to provide. Technically, can't say that truly happens in practice, but the step was first Maximus comes in as a government contractor and says, yes, you're eligible. So now you the applicant chooses your MLTC or managed care, and then that entity would come in to decide. That is now being shifted. And again, this isn't taking place immediately. We're going to get to the start point, but essentially, we don't know what's going to happen is the answer. And managed long-term care, we don't know what the future of that even looks like at this point. So because are they going to be able to provide these services? What's the contract look like with the Department of Health? Because again, the contract, unfortunately, New York State doesn't like to pay very much. So everyone involved is going to have to reassess what their role will be, what they choose their role to be. But the state law says it's going to be an independent assessor, which will be providing that eligibility and then assessment through the Department of Health contract, which means it might be Maximus that decides it all later on. It might be the managed long-term care. We just don't know what this looks like, and that's why we're continuing to work with the law department to clarify what those rules are. What we're all hoping for is a system that is more efficient, gets the services to the people who need them sooner, and can, from the state's perspective, be economical to them. So, right now.
So I don't know if you.
Go ahead.
I don't know if you. It sounds like we probably don't know, but someone's asking about Medicaid managed Medicaid, like BCO, MVP option. Will that all be the same like that?
Unclear.
And I have another comment. That's what's unclear, right?
That's what's unclear.
Okay.
So this may be a good time to point out that as this gets clarified, which we're hoping would be clarified by April 1 of 2021, because that's when the new start date is supposed to happen. It was originally October 1st. It was pushed to January 1st. There were reasons why that won't work. It is now April 1st of 2021. what we're hoping to do is continue to have conversations. Our group, the New York NALA and New York State Bar Association, actually has a meeting first week of December with the law department at the Department of Health for this reason of straightening out some of the details. Because some of the rules, basically the way the law was passed, is that the Department of Health commissioner has the right to pass regulations, which will put in effect and sort of interpret what the new law is. So what the scene will look like, what the landscape will look like, is wide open. We simply don't know, and it may get further delayed, and we're working on it. I was going to suggest that once things are clear, we should probably have another session in the spring. But right now, essentially, the law's been around for 7 months, except that Department of Health hasn't decided how's this going to work. And we have our concerns about that as well, because think about the backlog caused by COVID. Think about the backlog that existed pre-COVID. And now you're asking the Medicaid caseworker to look through 30 months of documentation, financial documentation, to determine if there's a penalty. You just took the time it took to review a file a lot longer. And there's pressure to get through these cases more quickly. And this imposes a much greater burden on the person applying for Medicaid, whoever's helping them, and the government. Okay? And we can come back to some of that. The problem is that, and I've been working with the State Bar as well as New York NALA, as well as we've had several different webinars through the State Bar Association. The answer is it's a moving target. And a lot of this is not yet determined. So hopefully it will be, but we just don't know. So, all right, so we're going to now go in greater detail through each of the changes. The first is the 2.5-year look back for long-term care services in the community. So we'll likely work the same way as the 5-year look back for Medicaid nursing home coverage. So I can explain how that works. Essentially, the local Department of Social Services determines if transfers were made for less than fair market value. They call that an uncompensated transfer or less than fair compensation. Then they impose a penalty. Now, how does that work? Typically, what we do is we look at those 5 years. I'm talking about chronic Medicaid because it's likely to work the same way. So we look at the 5 years of monthly statements, 60 monthly statements. You only have one bank account at ESL, we're looking at that. But if you have 20 bank accounts, we have to look at each one. And of course, I closed this account 2 years ago, opened up a new account. You have to follow the money to determine whether or not there were any transfers. So hopefully clients, people you advocate for, will tell you, oh yes, I gave someone a gift. I gave a family member a gift. Or I give them money at Christmas every year, $10,000, whatever it may be. Because that is going to come up and have to be addressed if they're looking for Medicaid, either chronic and now community. So what we could do in those cases is cure the penalty. And I see no reason why we couldn't cure the penalty for community Medicaid as well. It's complicated, it's highly technical, and if you do it wrong, you will suffer a greater penalty because you did it wrong. You'll wind up paying for more services than you needed to. So, and if that's nursing home care, that's 15 or 16 grand for every month you don't get approval for. So that can be very costly. The applicant is going to pay privately for the length of the period before Medicaid will kick in. What we expect to be able to do once the regulations are clear, we expect that if there were any gifts, we would try to get them returned, and then we can sort of redistribute. So in other words, typically with chronic nursing home Medicaid, if mom and dad gave away $100,000 over the last 5 years, if we got back the 100,000, we could then calculate that to determine what a penalty might be. But if it all comes back, there would be no penalty at all. But they now have 100 grand. So how do we fix that? Well, we could make a new gift, which is carefully calculated in order to figure out how long the penalty is for making a gift. In other words, we intentionally create and trigger a gift, which will trigger the penalty. But we're controlling it. So we know that there's enough money, either in what we haven't gifted, plus the applicant's income, that we can pay for those private care, whether it's in the community or nursing home, during that penalty period. So if there's a 3-month penalty or a 5-month penalty, whatever it is, we know Medicaid won't pay, but we have created a scenario where there is enough money to pay. Now, that doesn't work in every case, simply because what if the family that received the 100 grand spent it, they don't have it, they can't give it back. Plan B is maybe they got 50 grand and we can cure the penalty with roughly half. Plan C is nobody's got any money, and therefore you're simply going to have to live through the penalty period without services, which would be a terrible event for the applicant, depending on whether family could step up or whether they can pay privately for those services that Medicaid will not cover during that period. So I know that that is fairly complicated. That's why, there are a limited number of attorneys that could do this, that will do it, because a mistake is easy to occur unless you specialize in it. So that's something that we believe that elder law attorneys will be able to help with going forward, even if they want to live in the community. What's unclear, and some of the unanswered questions are, what is the penalty period? What is the penalty equation that we go through? Because there is a clear formula, but that's not necessarily going to happen. So, big question is, does this affect current recipients of long-term care services in the community? And based upon the language of the final bill, it's still unclear. Most of what I've looked at in the statute and in the interpretation of the changes to the New York State Code of Rules and Regulations and the actual statute and the social services law basically says that everyone who's getting services currently is grandfathered in. So they're not going to have to worry about it. But if you're going to apply for benefits after, and this is still a little unclear, it's probably going to be April 1st, but there's still some talk, and the language is it might be January 1st. If you apply after that date, you may in fact find yourself being subject to these new standards. So it will come into play at some point, but it's just unclear because the regulations have been fixed yet. Keep in mind that Medicaid has been around a long time, and year after year, there's tweaking in the state of how this is going to work. So this is new to the arena of community Medicaid, and they're still trying to figure it out at the state level. The future for
Miles,
yes, go ahead.
It was my understanding that the look back for community Medicaid was going to be phased in.
Yes.
So,
good question.
So
yes.
if that's the case, does that not start till April 1st? Is that phasing in of a look back period for community been postponed?
Yes. The plan is, and I think I've got another slide on this. First of all, let me answer it this way. The statute that was passed in April reverts back to a statute that was created in New York after the 2008 and 7 Deficit Reduction Act, which took place, became effective on February 8th, 2008. So that, we look to that as a guide. That guide phased it in. So if you applied 1 month later from the start date, you only had to show 1 month look back. And that would continue for 30 months until after the 30th month, you were now having to show 30 months. So yes, that phase in is still the plan. However, what has to change is there's a law that says any transfers, it references a law on the books that says any transfers after February 8, 2008. Well, that has to change. And there's already something that was passed by the Senate to change that, changed it to January 1, and we're hoping that gets pushed to April 1. And that is the role of the State Bar Association and New York NALA, that we are trying to make it very clear so these questions, these great questions you're asking, will have clear, unambiguous answers. So our goal is, yes, the look back period will be phased in. It will not apply until April 1. So if you apply in March, you will not be subject to a look back period. If you apply on April 1, you're going to have to show 1 month. If you apply on May 1, you're going to have to show 2 months, ongoing until we get 2.5 years into it from April 1 of 2021. Does that answer your question?
It does. Thank you.
Good. All right. So the next thing, and this is near and dear to my heart and Doris's heart, community pooled trusts, community pooled SMTs. Currently, it's an easy option. One option is if you're allowed $875 a month and you have income of $1,000 a month, you have to prove to Medicaid each and every month, here's how I spent that extra $125. Okay? Whatever that number is, that differential. You have to prove. The easier way to do it is simply give that $125 to a pooled trust, and it's deemed used and protected from Medicaid. There are criteria that the pooled trust uses it exclusively for your benefit, even though it's pooled with other sums of money, kind of misnomer because it's in your own account, it's in a sub-account, but basically pooled with other sub-accounts. And the future of that is unclear. There is a coalition that is working on that. Let's see if I have. Yeah. So the pooled trusts are designed to help those people find a resource so they don't have to tell the government every month, here's how I used my excess resources, my excess income rather. What we're shooting for is just the opposite of what is currently proposed. What's currently proposed is that there's a presumption that every dollar you put into the pooled trust is income to you and subject to a penalty. We're trying to do the opposite in that if you think there's fraud going on or you think it wasn't used for their sole benefit, then maybe it has to be proven. But to do it every month, even annually, seems like an utter waste of everyone's time and energy when if the trust is doing the right job, it is not, should not be subject to any kind of look back penalty. So I moved on to the next slide, which we've already more or less talked about, that we're now looking at April 1. There is some talk that transfers after January 1 will be included or subject to the penalty. We think that's likely to change. I already talked about that the current law in the books goes back to 2006. Senator Gustavo Rivera, who's chair of the State Health Committee in the Senate, introduced the bill. It passed the Senate, has not yet passed the Assembly, and therefore cannot go to the governor. But again, it's likely to be tweaked because we don't want it. That law changed it from February 8, 2006 to October 15, 2020. And since it's not really that's not really a magical date anymore, October of 20, we would hope that it would be extended into April of 2021. Time will tell on that. Okay, so we're going to talk about what that impact looks like on seniors and disabled individuals. Many of them may not simply be in a position to privately pay for those services. So it forces them to forego services that are otherwise considered medically necessary. This is similar to what we're dealing with today with COVID, is if people lost their jobs and they were run out of unemployment, they've got to make choices of the limited income they have. How do they spend it? Do they spend it on food or rent, or medical expenses? So that is a great concern, and I'm sure all of you share that, because going without may be the wrong answer, and it may lead to their further decline, and we don't want that to happen. That may be a result of this. Also, gathering the necessary financial records can be quite burdensome because even though it's only 30 months worth, 2.5 years, many people today either get it online and don't have physical copies, or they get the month, they balance their checkbook and throw it away. Others don't even balance their checkbook, they just throw it away. Yet others collect them in different rooms of the house until they piled up to the ceiling, but they look at them. So now to go collect this information could take them many, many, many months. And the problem with that, of course, is until they apply, there's no way they're going to get any services. The local Department of Social Services is required to make Medicaid determinations typically within 45 days. But even with current applications, that is an unrealistic time frame. We just don't work that quickly because there's been a hiring freeze at the county. They've promoted people to with no experience. In other words, we need help in chronic or community Medicaid. I know you've been doing child services over here. You come to this department and they have no training or limited training. So it's a real concern of how quickly and accurately those applications will be processed. So unlike most nursing home Medicaid applications, those are submitted when the individual is already living in a facility after they've received the needed care from a nursing home. Community Medicaid must wait for an approval before services can begin, unless, of course, they get an immediate or emergency relief, leaving them without care or assistance during what's probably a critical time for them to maintain their health and well-being. So we don't know when this penalty period is going to begin, because in Medicaid, for the people in nursing homes, the eligibility starts when you enter that facility, when you're physically living there. Well, if that's the case, then your eligibility doesn't start until Medicaid pays for some services at home. Well, they're not going to do that until you qualify. And so we have one of those catch-22s, is which comes first? I don't know. And so again, that's another issue that we're working with Medicaid to establish a time period, whether it's the date of application, whether it's the date you hired private home health aides, or the date your doctor said, although again, different criteria, is it 30 days prior to the assessment by some independent entity. So we just don't have that.
So Miles,
yes.
We have another question.
Sure.
Can attestation for immediate care be able to be used to expedite the Medicaid process?
Yes, you could still use immediate care. You could still use hardship. All of those are still available. And again, keeping in mind that today and through the end of the year, and for the most likely the first 3 months of the new year, these new rules will not be in place. So business as usual until then, and hopefully we'll have very clear updates prior to April 1st. But essentially, there is still the right and ability to get immediate care, emergency care, hardship cases. And I'm not sure, based on what we're seeing, whether the delay in getting the approval or the services will be any different. What's different is the criteria for qualifying, and then, of course, that the Medicaid caseworker has to look for and deal with and address a potential penalty. So we don't know how that's going to play out, what that's really going to look like. Does that answer the question?
Yes. We don't know how it's going to play out is pretty much the answer to every question.
Right.
It's terrible.
And that's why I said that up front, that it's still a moving target. I can only share with you what we know and what the consensus is. Again, keeping in mind that my group is talking directly to the commissioner, his team, and the lawyer in charge of Medicaid in Albany. So we're talking to the people who are decision makers in terms of creating regulations. And so that's good news.
So has it been determined that there are waiver programs that are exempt from the 30-month look-backs? That somebody's suggesting maybe that PACE programs?
Well, I haven't seen PACE mentioned specifically, but the federal government's 1115 waivers, which would be our TBI waiver, our nursing home diversion waivers, our New York State OPWDD programs, those are waived. These applications, these rules will not apply to those programs. Whether PACE is included, it ought to be, but again, if you're saving money, you have to apply this somewhere. So we're looking for that kind of clarification.
But it hasn't been exempt thus far, right?
No.
For PACE, it hasn't been exempt thus far, so I would assume that it's pretty much business as usual for PACE.
Right. And also, keep in mind that this is primarily for, is home health aides or the CDPAP program. So that's primarily how they're applying this. I will look that up, and I'll see if PACE has been given any specific waiver, and I will email you so you can email the group. So I will follow up on that.
Great, thank you.
All right, so these are the unresolved questions of the 30-month look-back period, and then we'll move on to the other troubling parts of this law. The current plan to phase in the penalty is the logical solution. There is no current plan in writing by the Department of Health. So these are we're getting this information from discussions, which unfortunately are Zoom discussions. At this point, they're not face-to-face, obviously. But when we get word that that's a good idea and we're going to go this way, it's still not an official ruling or regulation by the Department of Health. So while we think we're on the right track, things can change. As I mentioned earlier, the penalty formula is unclear. It's unclear whether we can cure the penalty. We think the gift and loan strategy will work, which is what we do now for chronic nursing home Medicaid. One difficulty would be determining the first month that the applicant is otherwise eligible, because currently it's defined by admission to a nursing home. And obviously that's not going to be the case. Same thing is true with the homestead. The house is exempt. But what if I want to transfer to my spouse because I have a greater likelihood of going into a nursing home? I want to get it out of my name. That's a legitimate transfer. Federal law and state law is a little different, because our state law refers to institutionalized spouses are allowed to do things. Here, the spouse is by definition at home, and the home would be exempt. So how do we penalize someone for an exempt asset? So that's got to be clarified. As I mentioned, the Community Pooled Trust, Supplemental Needs Trust, there is a group, I think there's about 22 Community Pooled Trusts throughout the state that are involved in this. So they have united to get a clear answer. Current position is that all transfers to a pooled trust equals a transfer subject to a penalty. We're working to reverse that presumption so it works to the benefit of the applicant. We talked about the immediate need. In a penalty case, you're not likely to get immediate need. It is applicable elsewhere. But if I have a penalty, I don't qualify until the penalty's over. So even though I might need immediate care, and this is troublesome, I might need immediate care, but I can't get it because there's a penalty, which is no different than if I went to a nursing home and gave away 100 grand. It might be determined that for 8 months, I'm private pay. Well, if I have no money, A, will I get into a nursing home? And B, if I get in, I can't pay them, and Medicaid won't pay them. So, this is a societal problem that is going to deepen with these kinds of regulations. So we expect the penalty period would start when the applicant starts to receive home and community-based Medicaid. So we'll see how that works. All right, so here was the good news I was saving for the end, but you already asked. We already revealed it. Does not apply to OPWDD services, TBI waivers, nursing home diversion programs. So fortunately, that's all I got for the good news. All right, any questions before we go into the second major change? All right, so we've got, this is pretty critical, that eligibility criteria for enrollment is changing. So now we have a heightened standard, okay? And actually, this is the slide that has the typo on it. It was late when I tweaked it last night. So applicants have to meet a heightened standard. So today you're aware of what the standard is. It was always a conflict-free assessment, but the doctor could have been involved. There could be notes, determination whether the individual seeking that coverage required at least 120 consecutive days of care, and if so, the qualified individual for enrollment gets some level of services in the community-based program, like the CDPAP program or the personal care services. Now, that's changed greatly. It says here, the next one is where there's a change. It says individuals will now need to be found as requiring at least limited assistance with 2 or more. It's actually more than 2. Sorry about that. So on your own, you got to change it. It's more than 2. Why they didn't say 3 or more, I don't know, but it's not 2, it's more than 2 activities of daily living. And it's specifically physical maneuvering. And that's a concern, because and it'll be pretty blatant when we get to the next bullet item, but if you have problem ambulating, that's one thing. You also might have to prove, well, if you can't ambulate, you probably can't go to the bathroom. So there's 2. So it's a question of, you have to be specific and outline the limitations with physical maneuvering. Now, the obvious concern is, what if you have dementia, Alzheimer's, or other cognitive impairment? That you meet that criteria if you have more than 1. Another typo there. It's not 1 or more, it's more than 1 ADL. So again, it's at least some supervision, but someone with Alzheimer's may have no physical maneuvering issues. They may walk, they may be physically fine. Well, guess what? They may also like to walk out the front door and walk into the middle of a main street. They may like to do lots of things that are, if they had the cognitive capacity, would not do it because it impacts their health and safety. But because of their dementia or other ailment, Alzheimer's or traumatic brain injury, they cannot contemplate the consequences of their action. They need to have more than 1 ADL that needs assistance. So if they can toilet themselves, groom themselves, walk, granted they might not be able to make a meal for themselves, but if they had, can they feed themselves, etc., they may not qualify. So that, I think, is real concern for how needy physically, mentally you need to be in order to meet the criteria, the heightened standard for these benefits. Again, this discussion is that it's not going to be applied prior. It's only January 1 of 21. We're pushing for April 1 where it would be applied. As we discussed before, the Department of Health regulations still are not final. And as we were talking about, this change will not impact current recipients of long-term care in the community. Anyone currently receiving benefits or receiving benefits prior to March 1, 2020 is grandfathered in, okay? There may be issues with recertification depending on how, we haven't seen the form yet, what they're asking on recert, but they're grandfathered in, right? So again, that's nice to say, but until we know that they're not going to do another assessment and hold them to a higher standard, that would be good to know if we can get clarification, confirmation from the Department of Health. Also, as we ended earlier, immediate need home care, undue hardship, all that is left untouched.
Miles, it's Doris. Can you just clarify exactly which typos are on that slide so I can make sure
Yes.
that they are sent in an email?
Yeah, it's slide 11. I actually tried to change it and then send it to you before today's presentation, but had some technical issues, I guess. So the second indented bullet down and the third, the one that starts with individuals will now need to be found as requiring at least limited assistance with 2 or more. It's with more than 2.
Okay.
And the one below that is more than 1.
Great. I will make sure that.
Someone with dementia needs at least 2. Someone without dementia needs at least 3. And that's a lot.
Gotcha. Yeah, it is.
That's a lot different. So again, keeping in mind with what was the goal was to save money for the state of New York. All right, so that's kind of a scary thought in terms of someone. I mean, I can envision many of our clients, and I'm sure for you in this group, either your loved one or clients of yours, how is it possible that we can meet that criteria? People are going to fall through the crack. And I think I'll get to one of the consequences of that slide coming up. So the third biggest change, which I don't believe is going to be as significant, it's just going to be more of a process, isn't going to come for 2 years. The first 2 are much more significant immediately, but basically the determination of whether you're eligible is going to go to an independent assessor that the Department of Health will enter into a contract with by October 1st, 2022. So assessments to determine what level of care is needed will now be done by an agency of DOH's choosing, as opposed to the agency that provided care. So remember, we talked about this earlier, Maximus is determined that you are eligible for these services. The managed long-term care program or the provider is coming in and saying, what do you need? Now it's not the provider coming in. So it's not clear what future applicants can expect when seeking the Medicaid bridge for home long-term care services. We don't know how these are going to be performed. We don't know who's going to perform them. And the criteria used to establish the levels of assistance and services needed, they haven't even been developed by the Department of Health, okay? Their definition of a qualified independent physician selected or approved by DOH seems to exclude the applicant's personal physician, who's going to know the patient the best. So I see that as a potential flaw in the system. Now, keep in mind, there's a flaw in the current system, many flaws, but one is that the agency that's getting a per capita fee every month. So if you get $1,000 for servicing this community resident, and you're determining how much care we're going to give them, if you're going to make a profit, you want to spend less than $1,000 a month that you're getting in order to provide services. So it's an inherent conflict of interest that they're supposed to provide any service needed and make up the loss with enrolling a lot of people that don't need a lot of services. I don't know how realistic that is or whether that's truly working, but you could see there's been a slimming down of companies that are offering Medicaid long-term care. So it's more likely, I think, that an agency that is directly providing services in the community will have more familiarity with the unique needs of those individuals as opposed to someone whose sole job may be, do I give them money or do I not give them money? I control whether they get government money. The appointment of an independent assessor allows for coverage determinations to be made by people who aren't regularly treating or interacting with these people receiving and needing the care. So that raises a concern about who'll be in and who'll be out. The other thing I wanted to point out is that housekeeping as a service is simply eliminated. So even if you're successful getting a loved one or a client on community Medicaid, housekeeping will not be one of the services after the effective date of this new rule. All right, so let me wind down with some good news. This comes from my role on the executive committee of the State Bar Association for elder law and special needs, as well as New York NALA, that the effort by the Medicaid Redesign Team 2 was really a slashing of benefits. So one of the things we have been fighting on chronic Medicaid for about 24 years is spousal refusal. And this is not the first time, but this was a strong effort by the redesign team to eliminate spousal refusal, meaning that no matter what their financial situation was, the spouse was required to contribute to the cost of care. So when we talk about traditional spousal refusal, it's one spouse goes into the nursing home, the other spouse is still living at home. Spouse at home is called the community spouse because they're still living in the community, but they are allowed to exercise their right of spousal refusal. There are consequences to that, but compared to $16,000 a month, they're much less expensive consequences. For community Medicaid, it is also available, and that has been protected. So a spouse may refuse in writing at the time of the Medicaid application to support or contribute to the cost of home care. The income and assets of the spouse of the recipient of Medicaid managed long-term care cannot be considered in determining eligibility if there's a spousal refusal. So in some instances, what we've seen is that the spouse who does not need the long-term care at home has significant income, which will, without the spousal refusal, they will be paying out of pocket, and they cannot afford to pay out of pocket, yet they're going to have to do some maneuvering such as spousal refusal in order to qualify for these benefits. So if spousal refusal didn't exist, then married couples would be more likely to discuss, should we get a divorce? And I could tell you, I'm doing this almost 40 years, and only 3 times have clients asked me, what about getting a divorce? And that's because there are great options available to work within the rules in the system to protect some assets. So if they took away spousal refusal, you would take away many of those options, and more people would be discussing getting divorced. It might have been
So
the
Miles,
most feasible.
we have someone asking, are the spousal impoverished guidelines changing? Spousal impoverishment?
The person who's asking that is reading my mind. That's the next slide.
Okay.
So I'll get there. Great question. So the spousal refusal ensures that the institutionalized spouse, or in this case, the community spouse, is able to receive Medicaid coverage, whatever is medically necessary, and prevents the community spouse or the living at home with the Medicaid applicant from, chances are they have a modest income and there's less to live on. As it stands now, it might make the difference between meeting all my monthly expenses and not when I lose the spouse that needs the Medicaid and has to contribute to that cost of care. It makes things very difficult for that couple. And now to answer that other question, spousal impoverishment budgeting rules were saved. Okay, again, the Medicaid redesign team number 2 tried to eliminate it, which would have done a lot of damage to this program in limiting people and the availability of the program. So the Medicaid redesign team 2 would have either eliminated the community spouse resource allowance or lowered it substantially. They wanted to lower, right now, the total resources, not annual, total resources a spouse can keep is just under $75,000 as a minimum. They wanted to lower that to about $25,000, which frankly, for most people, is the only safety net they have. It might be a savings account, it might be a brokerage account. For a lot of these people, it's a retirement account. Keeping in mind, retirement accounts are exempt. They are not counted. So you can get these services if you have $1 million in a retirement account. The problem isn't the cash in the account. The problem is your required minimum distribution will be very high. That has to go toward the cost of care. So that's a different issue we can deal with another time. But the point is that the lobbying efforts and the pushback prevented any change to the spousal impoverished budgeting. So I think the conclusion is that we have avoided forced and unnecessary skilled nursing facility placements, because many people faced with this choice, and I'd love to hear feedback from the group, many people faced with this choice would simply choose a nursing home because it might be the only choice. So I tried to leave a little time for any additional questions, answers. And also, if you prefer, stop sharing the screen.
No, you can keep the screen or go to the next, your last slide.
The last slide.
Thank you, Miles.
Okay.
There you go.
Okay.
It's your
any
smile.
Questions? That's my smile. Yes.
Yeah. Are there any more questions? I really appreciate this, Miles. I know that there are so many unanswered questions left, and we're all on pins and needles for those of us who work with clients who need services in the community and in the nursing home. So I will, you tell me when there's better and more firm information, and we'd love to have you back.
Well, I'd love to do it, because when knowing that there were great changes, when you first asked me, I said, sure, we'll have some clarification. And of course, as we got closer, our legislative group said, yeah, we don't have anything new. There was some tweaking, but I feel awful about trying to present the facts and clarity when the Department of Health simply doesn't have any yet. So I apologize for that, but this is what we know now, and we're hoping that we we'll have clear instructions and a clear path, and we're hoping we don't have to deal with it for another 5 months.
So just as a kind of a tag on to this webinar, the next month's webinar on December 16th is about pooled trusts and the options in the state. And we have representatives from 3 trusts, the Western New York Pooled Trust, NYSCRC, and Future Care Trust. And I believe the Western New York Pooled Trust has an attorney presenting who might have more guidance on how pooled trusts are going to fare with all these changes. But in the meantime, Miles, though, if you find something out about that, I'd really appreciate hearing about it.
Yes, I will.
I don't see any more questions, so you will be receiving an email from me in just a moment. It does have, Miles was kind enough to send a handout. Miles, I've made the corrections on that slide so that the information that you receive in that PowerPoint is correct. And, you know, there's just a feedback form. We'd really, really, really appreciate you just taking a few minutes to fill that out. It really helps with our funding to be able to provide these education sessions through NYSCRC. So if there's nothing else, oh, we do have another question. Will housekeeping be eliminated altogether?
That's my understanding, yes. My understanding is housekeeping is going to be eliminated. Right, right.
That's just terrible.
We agree.
Okay. So Miles, keep me posted, and
Will do.
I thank everyone. I thank everyone for joining us. I thank Miles for his time and his expertise. It's always much appreciated, and I hope to see you all next month at the Pooled Trust webinar. You can register on our website. So thank you, everyone. Have a great day.
Thank you very much.